Commission in the province. I would like to thank you, MEC, HOD, for being here today on this very important discussion we are having. Before we do dive straight into the meat of things, I'm going to hand you over to our Commissioner Tuli, the chairperson of this hearing, to administer the oath.
Molweni, MEC and HOD. Ninjani. I'm well. Welcome and thank you so much for joining us. My name is Commissioner Ntuli, as Dr. Carter has indicated, but I must also introduce my co-panelist, Dr. Fobosi, who is our external panelist from the Fort Hare University. So the three of us form the panel this afternoon, and we shall engage with yourself. Before we dive into our proceedings, we must conduct the administrative procedures. Do any of you have any objections to taking the oath this morning? Kumele umkhokhisi fine. Yes. Do you have any objections to taking the oath? No. And will all three of you be speaking this afternoon? Yes. Yes?
The presentation shall be done by one person, the HOD, but then if there are interactions, we shall come in to respond.
Okay, thank you, MEC. There's a microphone in front of you, so when you are speaking, please speak to the mic because the record must also capture. Then, having indicated no objections to taking the oath, may I kindly ask you to stand, state your full name, surname, institution that you represent, as well as the position that you occupy, please. You may stand.
My name is Noma Kosazana-Meth. I'm the MEC for Health in the Eastern Cape Province. So I represent the Department of Health.
Thank you, MEC. HOD. MEC, you can remain standing so that we can administer the oath.
Good afternoon. My name is Cindy Swagede, the acting HOD for the Department of Health, Eastern Cape.
Thank you very much. The latecomer has now excused themselves. MEC, do we know what's happening with the lady?
She has misplaced her handbag. She's worried. I said maybe she left it in the car, but seemingly she can't sit without knowing her handbag.
I see. If the handbag is in the office, it's safe. If it's either in the office or her car, it's safe, unless she lost it between her car and the office.
Did you find your handbag?
Ma'am, have you found your handbag? Okay. Okay, thank you very much, ma'am. Can you then maybe state your full name, surname, institution you represent, as well as the position you occupy, please?
Oh, okay. Thank you very much, Commissioner. Honorable MEC, I'm sorry for being late. My name is Mia Kazimonkwe. I'm the DDG for District Health Services Management in the Department of Health.
Thank you. Thank you, DDG. We hope that you don't lose people's health files the way you lose your bag.
No.
Okay, then, having indicated no objections to taking the oath, can I please confirm with you that the evidence you shall give this afternoon will be the truth, the whole truth, and nothing but the truth? If so, please raise your right hands and individually for the record state, "So help me God."
So help me God.
Is the microphone on? Just
Yes.
speak to the mic, just, yeah.
So help me God.
Thank you.
So help me God.
Thank you, HOD.
So help me God.
Thank you, MEC. You may be seated. Thank you very much. You are duly sworn in. Then, MEC, you've indicated that the HOD will do the presentation. Then HOD, over to you. You will have about 20 to 30 minutes, depending on how long your presentation is, and thereafter, the panel will engage with you. As you are aware, we are here on the topic of road infrastructure and, of course, its effect on health facilities and access to the right to health. Over to you, HOD.
Good afternoon, Commissioner, Dr. Fobusi, Dr. Carter. I will zoom straight to my presentation without going back to the questions that were sent to us by the Human Rights Commissioner, by the Human Rights Commission Commissioner. Thank you. I will be talking about the impact of poor road infrastructure on access to our health facilities or to healthcare services for the communities of the Eastern Cape. In my overview, allow me, Commissioner, to talk on the road infrastructure, which is the key provision of quality healthcare service to people of the Eastern Cape. Due to geographical size of the province, there is a strong need for quality road infrastructure to bring services to the communities and support the existing initiatives to improve access to healthcare services. Besides the provision of the healthcare services, the department is responsible for transporting staff and other goods and services to communities that are in need. These goods and services include, but not limited, the medicines, health technology equipment, which is our medical equipment, and related supplies. Unavailability of these goods and services also compromise the department's ability to provide quality and effective health care services. Due to poor road infrastructure in other areas of the province, there's a delay in responding to emergency from the communities. Certain areas become inaccessible, especially due to heavy rains that have led to damage to the existing road infrastructure. Delays in responding to emergencies lead to possibly harm or disability or even death. These are often reflected as litigation against the Department of Health. Transport-related accidents are among the top 5 causes of non-natural causes of death in the Eastern Cape. Overview. Due to the poor road infrastructure, the Department of Health spent a significant portion of its budget in maintaining the vehicle fleet. The inadequate road infrastructure also leads to frequent motor vehicle accidents, which puts pressure on the Department of Health Services. The department participates in the following structure to continue to engage with the local and the district municipality to draw attention to various social determinants of health, which include road infrastructure, which are participation in the IDPs through districts, participation in the district development model, district municipality one plans, and provincial clusters. Coming to coordinated care via effective and functional referral system with hub and spokes connected health facilities to health care teams. We talk of spoke, hub and spoke model in the Eastern Cape, where we say if the patient is coming from a deep rural hospital, if there's a hospital on the road, as this patient is being transferred, it must be taken care of and be stabilized and move on to the next hospital where it is referred. If you look there, we've got different kinds of, the different levels of care, starting from the clinics. I'll start from the community or home-based care at home, the community outreach services, the clinic community health centers, the clinics and community health centers, district hospitals and community hospitals, regional hospitals, tertiary hospitals, including the central hospitals. Those are levels of care within the health system. If we talk of the service delivery platform within the Department of Health. Coming to the distribution of facilities in the Eastern Cape, Alfonso District have 72 clinics and 2 community health centers and 6 district hospitals. Amatole District Municipality has got 143 clinics, 5 community health centers, 12 district hospitals. Buffalo City has, amongst the Amatole hospitals, there are 2 specialized. It's a mental health care hospital and a TB hospital, to make that 12. Buffalo City has got 74 clinics with 5 community health centers and 2 district hospitals. Chris Hani municipality has got 152 clinics, 5 CHCs, that is community health centers, and 14 district hospitals. When we move to Joe Gaibi, it has got 52 clinics. It doesn't have any community health center and 11 district hospitals. Nelson Mandela Bay, it has 39 clinics, 9 community health centers, and 1 district hospital. Oliver Tambo District Municipality, 142 clinics, 11 community health centers, 9 district hospitals. Sahrc Batman with 60 clinics, 3 community health centers, and 10 district hospitals. Meaning that the province has got a total of 734 clinics. Chris Hani, OR Tambo, and Amatole District have the larger share of clinics in the province. Nelson Mandela Metro and Joe Gaibi District has the lower number of clinics, 39 for Nelson Mandela and 52 for Joe Gaibi respectively. Number of clinics is related to the population size and the geographic area. Coming to Alfred Nzo, when we talk of the higher level of care in the health services, we've got regional hospital. If you look, the Alfred Nzo and Amatole don't have the regional and provincial tertiary institution. They've got a 1 TB specialized hospital, Alfred Nzo, and in Amatole there's 1 TB hospital and 1 mental health care institution, Tower Hospital. Buffalo City has 1 regional hospital, has 1 tertiary, has 1 specialized TB hospital, and also specialized and other specialized hospitals. We call the others as other. We do have a hospital for frail and care in Vincent. Then when it comes to Chris Hani, we've got 1 regional hospital and 1 specialized psychiatric hospital. Move to Joe Gaibi, you won't get those hospitals. They are referring to Chris Hani. And then with Nelson Mandela, he's got regional 1, 2 provincial, 3 TB hospitals, 1 psychiatric hospital. Oliver Tambo District, we call it OR Tambo, with 2 regional hospitals, 1 other specialized, which is the Bedford Orthopedic Hospital, and 1 central hospital. Then with Sahrc Batman, we've got 4 specialized TB hospitals, 1 psychiatric hospital. In total, we have in the Eastern Cape 5 regional hospitals, 3 provincial tertiary hospitals, 10 TB specialized hospitals, and 4 psychiatric hospitals. In other specialized hospitals, we've got 2, and 1 central hospital. If we talk of the facility distribution norms, in urban areas, this upper limit is up to 35,000 for clinic and up to 180,000 for SCHC. Those are norms and standards to say you are building or you have a clinic or the number of people that it must serve. Then if we talk of the level of care, the maximum travel time should be 20 minutes, which is 5 kilometers. I should think we adopted that one from the Alma Ata Declaration. And then minimum population should be 8,000 to 12,000. Then with the CHC, we should be 40 minutes a walk to the facility.
HOD, just please a reminder, because the record must capture on the mic, so just bring it a little bit closer.
Okay, thank you, Commissioner. CHC should be 40 minutes walk to the CHC, which shouldn't be above 40 to 50 kilometers. It must save 50,000 to 90,000 population. Level 1 district hospital should be an hour drive, and then the minimum population should be 3,000 to 900,000. 300,000 to 900,000. For level 2 regional hospital, it should be 2 hours drive, which is having a minimum population that it must serve 1.4. Then 1.4 million. The level 3 tertiary should be a 2-hour drive to the tertiary hospital. It's having all different kinds of specialists. Ours is in Mthatha, which should be serving a minimum population of 2.2 million. Maybe this map below is giving illustration of how the hub and spoke model in the Eastern Cape we have set. Those are the kilometers I just spoke about, so that a patient can access a higher level of care. And then as it is driving to the higher level of care, should need arise, it must stop in a certain hospital to be stabilized before it can move to the next level of care to save the lives. Distribution of health facilities by geographic size of the district. This slide is talking to the population size, the area size, and the total number of clinics. The ratio of health facilities to geographic size. The district with larger geographic area seems to have fewer health facilities for their geographic size. If you look there, I'll just be quick to say Alfred Nzo is serving a population of 831,913,000 with an area size of square meter of 10,731.2, with total number of clinics that are 72, which gives us the ratio of health facility to geographic size of 149.0. Amatole having a population of 791,000, meaning that we size area of 294.9 square meter, and the total number of facilities are 143. There's a red highlighted without going through all of them, where it says we have got the Joe Kabi that is having for total number of 52 clinics with a population size of 343,094 with 52 clinics, and Krisani with a population size of 716,392 with 152 facilities. In these districts, communities are expected to travel long distances to access their nearest clinics. For example, Sahrc has a large distance between health facility and is so vast, meaning that it's so widespread. And one clinic per 970.7 square meter per kilometer, compared to the Buffalo City, where the ratio is one clinic per 34.3 square meter. The Department of Health, therefore, uses mobile clinics to reduce the distance traveled by communities to access primary health care services. Emergency medical services. I can even add satellite clinics established to ensure that people are accessing the services nearer where there is no mobile clinic. We do have satellite clinics. The emergency medical services vehicles. When we look at Alfred Nzo, we've got a number of 64 ambulances. We've got cars that are called patient transport vehicles. Those cars are the cars that are taking patients from one lower level of care to upper level of care and transport back to the from higher level of care to lower level of care. We have got about 4 rescue vehicles, and response vehicles are 19 and 1 admin. When you look at Amatole, they've got about 62 ambulances and 17 patient transport vehicles 2 rescue ambulance, and 18 response vehicles, and 2 administration people. Buffalo City has got 44 ambulances, patient transport vehicle are 13, 3 rescue vehicles, and 12 response vehicles, 1 administrator. Chris Hani District has got 65 ambulances, 32 patient vehicles, and 6 rescue vehicles with 16 response vehicles, 2 admin. College of Emergency doesn't have ambulances. It has got 5 patient transport vehicle, 0 rescue, 4 response, and 1 admin. Then, meaning that 1 admin vehicle, I'm sorry, because the admin must move from meetings to meetings and must assist when there's an emergency, when there's a need. And then we've got head office, 0 ambulances, 0 patient transport vehicles, 0 rescue vehicles. We've got 1 response vehicle and 3 vehicles for administration staff. Joe Kabi has got 44 ambulances, 18 patient transport vehicles, 5 rescue and 15 response, and 2 admin transport. And Nelson Mandela Metro has got 37 ambulances, 13 patient transport vehicles for rescue, 17 response, and 2 admin vehicles. OR Tambo, 74 ambulances, a patient vehicle at 32, rescue vehicle 4, and response vehicle are 19 with 2 admin vehicles. Sahrc Batman has got 57 ambulances, 34 patient transport vehicle, 5 rescue vehicle, 16 response vehicles, 2 admin vehicles. In total, in the Eastern Cape, we've got about 447 ambulances. Patient transport vehicles, 188. Rescue vehicles are 33. Response vehicle are 137. And admin are 18. Coming to the development of the EMS fleet from 2015, 2016 financial years to date, which is 2023-24 financial year. The 4x4 ambulances and 4x2 panel van ambulances, 2015-16 financial years, we had about 23% of them, meaning that the total number were 406. 406 still in 16-17 financial year, which is 35%. And then 2017-18, 447, which is 42%. 2018-19, we had about 447, which is 68%. And then in 2019-20, we had about 68%, which is the total number 447. 2020-21, 447, 64%. 2021-22, 63%, which is 447. At the present moment, we have 447, which is 50%. Without going more to response and rescue vehicles, the challenges here is the high transfer rate of patients in between hospitals requiring double stretchers, and most 4x4 bakkies come with a single stretcher. Lack of 4x4 panel vans with double stretchers in the market. If available, they come at very expensive cost. Dwindling EMS fleet budget annually, it's never enough. Long lead times for original equipment and manufacturers, it's a serious challenge. Supporting medical legal intervention, there are 3 ambulances that are wheelchair capable. Sorry. All right. these ambulances are able to take 3 wheelchairs at the same time for the people that are wheelchair bound. Thank you very much. Other fleet, I won't dwell more. We do have mobile clinics, total number of 96. Forensic pathology vehicles are 68. Dental vehicles, trucks are 6. And admin fleet is about 673 across the province. I won't dwell more on the number of days where our ambulances are grounded because they must go for repairs. If you look at Alfred Nzo, total number of vehicles are 62, but only 26 that are operational. Currently, it's 26. The days the ambulances are grounded, that is, it's 7 days. It's 30 to 60 days, meaning that in the garage, you'll find we have 7 in Alfred Nzo. 61 to 90 days, it's 2. 91 to 120 days, it's 0. And then above 121 days, it's 1. This is showing that we have got a grand total of grounded ambulances of 36 in Alfred Nzo. I will quickly not go back to say how many days. In Amatole, there are 17 that are grounded. In Buffalo City, it's 21. Krisani, 26. Joe Gabi, 20. Nelson Mandela, 6. OR Tambo, 28. Sarah Patmani, 36. We've got about 190 ambulances on repairs at the present moment. I have a slide about the analysis of top 5 vehicle reasons for downtown. Engineer repairs, 51 instances. Engine-related repairs are most frequently occurred type among the ambulance repairs, with 51 instances. You repair the engine now and again. Brake repairs are 38 instances. Brake-related repairs come second in the frequency, with 38 instances. This is crucial as ambulances need to have reliable braking system for safe transportation of patients and quick stop during emergencies. The clutch-related and gearbox-related repairs, 30 instances. Clutch and gearbox repairs are the 3rd most common type with 30 instances. Ensuring smooth gear shifting, transmission operation is essential for maintaining the drivability of the ambulances during the emergency responses. The power issues, we've got about 24 instances where there were 24 instances where ambulances experienced no power issues. This can be a significant concern as it may relate to various vehicle components, including the engine, electrical system, or battery. Accident-related repairs, 13 instances. Accidents leading to various types of vehicle damage accounted for 13 instances. These repairs are important not only for the vehicle's functionality, but also for the safety of patients and emergency responders. There are many instances where ambulances have collided with animals, more especially at night. Fleet risk accident register, I can share it if you want, but if we look at the fleet accident register, the total number as we speak, Alfred Nzo, it's 20 vehicles. Amatole 19, Buffalo City 2, Krisani 15, Joe Gabi 16, Nelson Mandela 9, OR Tambo 35, Sarah Patmani 29, totaling to 145 fleet risk accident register having those vehicles. There are 145. This is a record of ambulances that have been involved in various road accidents. Majority of these accidents happen in rural areas or in rural roads and may involve hitting wild animals, unfenced regional roads. I will just quickly move to specific challenges faced by emergency services in accessing rural communities, especially due to the condition of the roads. Poor road infrastructure, delayed response to an emergency, has a high risk of motor vehicle accidents, has limited access to health services, which leads to increased morbidity and mortality amongst our communities. Specific challenges are as follows: unsafe roads, which may cause increased traveling time when responding to emergency cases. The poor state of the roads affects the wear and tear of the emergency vehicles. Certain communities become completely inaccessible. We call them hard to reach areas. You remember during the hard rains, other bridges were wiped away, making it very difficult for an ambulance to access the patient. Access to mobile clinic services becomes irregular as vehicles break down and become unavailable for extended periods of time. Service providers delivering goods and services tend to be reluctant to travel to certain communities, hence affecting availability of health services at times. Maybe for trying to move faster, we do have indicators that we measure our performance against within the EMS, that is Emergency Medical Services. This information is providing how inadequate road infrastructure in the province has affected the ECTOH ability to provide timely medical assistance. The Emergency Medical Services Program tracks response time to priority 1 emergency on a monthly basis. That is an indicator. The Emergency Medical Services Programs track response time to priority 1 emergency on monthly basis. The indicators that are on the annual performance plan as determined by the National Department of Health. Priority 1 emergencies include maternal and neonatal related cases, heart-related complications, etc. They are mainly life-threatening, therefore required. These are mainly life-threatening, therefore requires immediate emergency treatment. Priority 1, 2, and 3 cases are often the less critical type of emergencies. With type P2 cases are patients that are not critical but need to be transported on a stretcher. There is no obvious complication that could be debilitating in those patients. P3 cases are people with minor ailments like toothache, tummy ache, etc. They can wait a little longer or being collected using ordinary vehicle instead of an ambulance. The MS targets to respond to P1 emergencies within 60 minutes in rural districts and 30 minutes in 2 metros. We're supposed to be there in 60 minutes in a rural for P1 and 30 minutes in a metro or urban district. If we come to performance, the EMS P1 urban response under 30 minutes in 2015-16 we were ranging between at around 55%, 2021 48%, 2021-22 at 48.18%, giving a variance to 2015-16 of minus 6.82%. The total number is 17,210 calls over 31,317 collected. 31,317 collected in 2016. 2021, 21,910 over 45,618. And then the 2021, 26,228 calls with a denominator of 54,436 calls. I will quickly move and unpack urban caseload and the urban caseload, that is from July 2023 to September. The total number of cases in Buffalo City in July were 4,529, August 4,227, September 3,495. Total case in Nelson Mandela cases 7,181 in July. Those are the calls for ambulance cases collected or fetched. August 7,620, September 6,910. Total number of urban calls were 11,000 in July, 11,710, 11,857 in August, 10,405 in September. I won't dwell more on the percentage of calls. When we look in rural, that is Alfred Nzo area, we had 229 calls July, 1,173 calls in August, 1,324 in September. This has, if we look at these numbers or the work done, ECTOH allocated additional resources to ensure that we render quality services, or we have introduced specific strategies to address these health services and challenges posed by inadequate road infrastructure. The question follows to say measures that we put in place to ensure that critical medical supplies and personnel can reach remote areas efficiently, efforts in place to provide alternative health care, transportation of patients, particularly in emergency cases. With the road infrastructure and health service delivery, the following strategies have been introduced. I should think now I'm coming to where you wanted to understand exactly what are strategies in place to mitigate these challenges. The following strategies have been introduced to address the challenges of access to various communities. We have mobile clinics. These are used to access those communities that are not large enough to have a fixed clinic and are far from the existing fixed clinic structure. Outreach services is another measure. This is part of the community-based service wherein clinicians conduct full outreach to communities, bringing the minimum package of service, including immunizations, family planning, and basic screening for communicable diseases, etc. Ward-based primary health care teams, integrated school health services, and another measure to reach out to our communities and also to our schools. We do have a program on centralized chronic medicine dispensing and distribution. We call it CCMDD, where we ensure that our patients, they get their medicine, if it could be possible, at the doorstep, where we use the Clicks Pharmacy, Abo Boxer, the Chief's House, okanye Kwasbonda, or to the ward councillor or the nearest shop in the village where they can go and fetch their medicine. And we even have some kind of, we have linked this service to NGOs where you would find in an area there's a pillbox station. I would say, yes, your patient name, they would go and open and get their medication using a code and take their treatment from that. The road infrastructure and health service delivery. There's a question that says, has the ECTOH allocated additional resources or introduced specific strategies to address health services delivery challenge as posed by inadequate road infrastructure? The mobile clinics. Our answer is a strategy. There are additional 54 mobile clinics vehicles further distributed to the districts to make a total of 148 mobile clinics vehicles. Distribution of vehicles prioritizes most remote areas so that we can improve access. To address bad road challenges, there are 4x4 vehicles that are procured to resist damages. With the outreach services and the Tuma Mina campaigns, these services are scheduled to catch up with disease screening, vaccination, as well as acute ailments and chronic medication and non-adherence, some associated with poor access. We deal with those issues of non-adherence due to long distance to go and fetch the medication. So these Tuma Mina campaigns and outreach services assist on that. Maybe just to mention, if I talk of the ward-based outreach teams, they are forming part of the National Health Insurance to say, let's reach out through the ward-based outreach teams, accompanied by the district specialized teams, where there would be a doctor and an advanced trained nurse. Road infrastructure and health service delivery. Specific strategies to address these service delivery challenges. I've mentioned the ward-based primary health care teams. We call them WOBOCOTS nurses. There's a community health workers and a health promoter in that team. These are sustained health services through health teams that bring services. The ward-based outreach teams is another means to curb inaccessibility to mostly needed promotive and preventive health in our communities. They serve as a link with the local clinic and the mobile clinics. I've mentioned the centralized chronic medicine dispensing and distribution. Specific strategies to address the health service delivery. There are health posts and satellite clinics. I mentioned when I was talking of mobile clinics. These are another health facilities that are established in area of poor access to the fixed health facility, where access through mobile clinics is also inadequate. Delivery of regular health supplies to facilities, medicine, equipment and good services, provision of supplies and commodities in facilities affected in bad weather and bad roads, and effects are costly on both communities and the department. More frequent deliveries are scheduled than required. More stock is kept than required, meaning that you have to stock more so that when there's a challenge of accessibility, you've got enough stock of medicines and consumables in your facility. Just to mention, under the CCMDD program, the Chronic Central Medicine Distribution and Dispensing, as at end of September, there were 390,198 active patients on the program. Majority of patients are at OR Tambo, followed by Amatole and Buffalo City. We do have pickup points for these districts. Currently, there are 12 in Alfred Nzo, 22 Amatole, 38 in Buffalo City, 13 in Kresani, 6 in Joe Gabi, 58 in Nelson Mandela, 39 in OR Tambo, 12 in Sahrc, giving us 200 pickup points. This is an innovative idea to reduce number of visits at the clinic and traveling to the clinics to collect medicines. We do have partnerships to bring medicines to the communities in the areas of Mpashe and Muma, and the plan is to expand to other districts. We've got partnership with the TB HIV Care Association. It's an NGO in Mpashe, Muma, in the whole of Amatole district, I would say so. The department is partnered with NGOs, CBOs, traditional leaders, councillors, religious leaders, and we are implementing the differentiated models of care, including this central chronic dispensing and distribution of medicines to our patients. We do also have Doctors Without Borders. We call them MSF, Medicines Sans Frontier, Medicines Sans Frontier. That is Doctors Without Borders, that are working with chiefs in the villages, and in Tafalofefe, Maqibe, Ngosi clinics, They have got many pickup points that they have identified and made a lot of, they've made a lot of relations with the community leaders. I won't dwell more on the number of the names of villages where these pickup points are. We do have aeromedical services in the Department of Health, which are playing a major role in decreasing mother and child mortality and morbidity rate. Eastern Cape has 80% rural roads. The bad road surfaces causes maternity patients to complicate over long distances. We are also exposing the communities and rural care facilities to our ALS practitioners. That is advanced emergency services. We do have three helicopters in Mthatha, Eastland, and Port Elizabeth. A contract extended for a period of 3 years, and then the majority of the calls are inter-facility. We do have also relations with the Western Cape, where the Mercy Medical Ambulance would come and fetch a baby to Red Cross. There is that relationship we have with the Western Cape for the children to be admitted at Red Cross. There is 30-hour flying time per month that is contracted with these three helicopters. In summary, Commissioner, the state of road infrastructure remains a challenge, especially in the rural communities. The Department of Health continues really with a commitment to reduce out-of-pocket costs of accessing health services by using mobile clinics, ambulances, and PTVs to bring services closer to our communities. Frequent breakdown of vehicles due to road infrastructure increases the cost of providing our health services. The inaccessibility of certain communities due to road infrastructure has negative impact in the health outcomes, and though the DOT is working on addressing the road infrastructure, that is the Department of Transport, progress is also reversed by delays due to delayed impact, or can I rephrase? Though Department of Transport is working on addressing the road infrastructure, progress is also reversed or delayed due to impact of climate change on the road infrastructure. A lack of adequate road infrastructure will affect mobility of medical staff, doctors, patients seeking medical attention in rural, remote areas. With improved road infrastructure, patients can easily get a medical attention they need in time. It also helps doctors and medical staff travel to assist the people in need, especially when it comes to emergencies. This is in turn will help to reduce the maternal mortality rates, deaths, and there will be easy access to public hospitals in remote areas. And also there will be reduced litigations against the Department of Health. I thank you, Commissioner. Thank you, Elisa.
No, thank you very much, HOD, for that comprehensive presentation. We will start with Dr. Carter in engaging with this presentation, and thereafter Dr. Fobosi. Dr. Carter.
Thank you so much, Commissioner. Thank you, MEC, HOD team. You have provided quite a lot of information, and I think it's very valuable for us. We will also go forward now and unpack the info that you have sent on your presentation. And I think you confirm our suspicions that the lack of road infrastructure affects your budget, because from your presentation it looks like there is about, I think is it 190 ambulances currently in repairs. So it's 190 ambulances that are not on the road, and some of them may have been directly affected by the road infrastructure. Then that's the first suspicion that you've confirmed. Number two is that your medico-legal costs appears to be closely related to the delays in which you are not able to get to, is it P1 cases under 60 minutes. So I've also looked at your stats. It looks like 65% is the going rate. 65% of P1 calls would be responded to under 60 minutes, and the rest may be delayed. So that may be also then causing fatalities, if we can put it like that, and then the medico-legal costs that would go hand in hand with that if there were claims to be made in respect of that. So there's a few suspicions that you have confirmed here today. And we thank you for that data, because you objectively provide us with the information that sketches a picture why communities may feel that they are not accessing healthcare to the same extent as their urban counterparts would. Now, I would just like to ask a few follow-up questions. Now, the first one is, how many 4x4 mobile clinics do you have? I know you've provided some numbers on the EMS vehicles, but the mobile clinics specifically, are they able to drive on these roads? That's the first one. Then the second one, are you able to give us a number, perhaps a percentage, on what your budget towards maintenance of these EMS vehicles is? Because we would also want to make the comparison with other provinces. We've heard here that during the proceedings that only 9% of the roads in the Eastern Cape is surfaced. Only 9%, vis-a-vis the national standard of 25%. So we would like to see whether we can somehow see a comparison between your maintenance costs with a 9% province against another province, perhaps. So that would be very valuable for me. And we've asked the additional resources question because we know that there is a disparity in terms of the road infrastructure between provinces. So I just want to hear you on that, and whether that case for the Eastern Cape Department has been put to Treasury. Whether that argument has been made to Treasury to say, you know what, we've got 9% of roads, which means our vehicles have to trample on unsurfaced infrastructure. It may lead to a lot of damage, which means our vehicles are standing, 190 of them, up for repairs, and not reaching the patients, and it may affect our service. So I just want to know from your side, HOD MEC, has that case been made as expressly, perhaps, as I've put it here today? And if so, what has been the response? And if not, is that something that we need to consider going forward? So those are just 3 specific questions. If the data is not available here and now, we will just request that to be provided to us. But I would still like to have your views on this, if possible. Thank you so much. Thank you, Commissioner.
HOD?
Thank you very much, Dr. Carter. Commissioner, it's clear really that there's a serious challenge when it comes to budget that we spend on repairs of vehicle. The department is sourcing those services with the Department of Transport. The amounts and the amount we spend in terms of repairs, I should think that cost of the maintenance costs, we can arrange that information. It is not at hand at the moment. With the additional resources, I've made mention, maybe I haven't started with the first question. With the additional resources, we've made mention of the number of clinics I'm sorry, mobile clinics that were procured and distributed this financial year. I'm trying to look at the slide now. Help me, Mia. Yes. Yes, yes. Yes. I've made mention under the challenges to say the high transfer rate of patients in between hospital requiring double stretchers and most 4x4 pakis comes with a single stretcher. You know, lack of 4x4 panel vans with double stretcher in market, if available, they come so expensive. It's difficult to get those 4x4s that are able to get into the to the rural areas. But we are with Mr. Machokiana, who can assist us in summarizing how many 4x4 mobile clinics, how many 4x4 ambulances. But with the clinics that were recently procured are 4x4s, so that they can resist bad roads. Maybe MEC want to add something, but with the budget, it's a serious challenge in terms of meeting the needs of our communities. Has the argument made with the Treasury? Maybe I'll give off to my MEC.
Thank you, Commissioner. Thank you, Doc. Thank you, Acting HOD. We're given 4 chairs here, and because they were late, the other one, who is the GM, EMS Services, could not come. The chair is vacant. He's outside, and that is going to give us some serious challenges in terms of the detail now, because I don't want us to say everything shall be submitted, even the easiest thing that would have been responded to in this meeting. So with a due diligence chair, if then he can be allowed in and Miagas can move closer. I know Nenengak is a hips upper, so thank you for those important questions, Commissioner Dr. Carter. Let me just go to the one that I think is the easiest for me, the one of presentation to Treasurer. And request for additional budget. We are a department in trouble because we're responding exactly to the questions. It didn't give this background. That is, we start the financial year, this financial year, we started it with 4.6 billion rand budget shortfall due to accruals and payables caused by medical legal claims. And unfortunately, we are the only ones that get litigated as a Department of Health, regardless of the determinants of the social determinants of health, that in particular talks to the issue of roads, which contribute massively, even if there's been no scientific study conducted to say, of all these litigations that we receive as the Department of Health, in particular for maternal services, what is the contribution? Because there are 2 contributors to the medical legal claims. It is the maternal services and also the orthopedic services. If you look at orthopedic services themselves, they talk to motor vehicle accidents that happen, and they end up coming to us as the department. And should we be sent to have been negligent, then it's our own baby. So nobody understands that the importance of the social determinants of health talks to the health not being, the health service not being a Department of Health issue. So we are in that problem as a Department of Health, and we are the only ones that we must fend for ourselves when it comes to that. Even if you can present yourself. As a department, I think I once shared with you, Doc, that is this department, as we get to October, each financial year, the money is depleted. There is no money, equitable share. So we rob Peter to pay Paul up to the end of March, because monies, when they come, we put them in that big hole that we start the year always with because of the cumulative medical legal claims. So I don't think expressly there's been a presentation or an argument to Treasury that talks to the issues of the roads and the maintenance budget that is related to our topography and all the difficult terrain of our department, because there are people who just are always having problems. So we always have to make people understand that we don't have money. When time for adjustment budgets come, we must be able to present ourselves, but unfortunately, we are almost treated like any other department. There is no special attention that is given to us, including the issues that we find ourselves having: irregular, unauthorized, wasteful and fruitless expenditure that is caused by a majority of these medical claims because we can't budget for them. The law doesn't allow. So at the end of the day, we pay lots of money for things that we did not budget for, and we are seen to have spent irregularly. And when we present our case, even when there is acceptance from the SCOPA or any other oversight body, but I have never seen in the 2 years I've been in the department the realization when there is condonement that there is that bill that gets passed now, so that at least that money can be given back to the department after it has been condoned that we had to pay for this. So we are in that very difficult situation. I remember the other day I was engaging the MEC for finance. I think it is just before the end of the year last year. It is only then when he said, "Oh, I understand this thing." Even though we continue to present our case, be it in the cabinet, be it in the legislature, because we also got medical legal strategy that talks to what is that we want to do, but we also in that medical legal strategy explain our difficulties, because the issue of medical legal, the litigations are multi-pronged. The issue of us not being able to respond on time, leading to those expecting mothers delivering on the road, and also not having enough money to employ the advanced life support. When you get to our ambulance, sometimes you get only the basic. The basic is like a conductor if it was a taxi. Somebody will just open the door, bring the patient in. But if then there is emergency to attend to before that patient gets to hospital because of long distances, we're always found wanting. If you can even get the information in terms of the categories, you've got the basic life support, you've got the intermediate. Now that this guy is there, he's going to help us with the technical terms. The intermediate life support, then the advanced life support. The norm is that you must have many advanced life support, so that the pre-hospital, before you get to hospital, any intervention that is needed, you have those people in an ambulance. So with us, we've got many of the basic support, and we've got lesser of the intermediate, and then less of the advanced. So even when you take those people with the ambulance to where they must go, there's a problem. In the shortage of ambulances still, the norm in South Africa is 1 ambulance per 10,000 population. With Eastern Cape, it's 1 ambulance per 20,000. Even in that 1,000 per 20,000, majority of them, they break down, as it was reported here. And sometimes, because of not having money, even those that are not broken down, they are parked in the ambulance bays because we don't have enough personnel to operate the ambulances. So the situation is quite dire, and I think we try to present it, but with the provincial revenue fund, that is also not enough for all the other departments. We are treated like others, that we are the most funded. I think the most funded department, number 1 is education, then we are number 2. But still, when I look at how we are dealing with life-saving, I think it's not enough what we are getting. So we are underfunded. But when we present our case, it's like we know your story. Nobody maybe is prepared to have a new listening ear, come up with a new intervention. So we are in that situation. I'm sorry to be long. I'm just trying to paint this picture of what this department is going through, not only just because of the medical, of the road infrastructure generally. This thing is a vicious cycle. If you don't deal with that one, you'll continue to have medical legal claims that will continue to make this department and the government at large to have monies that must be spent to try to pay for medical legal claims. So get these additions with your permission, Chairperson, from the third party.
Before you come in, DDG, I see the gentleman from EMS who is now on his phone. My good sir, I'm going to ask you to take this engagement seriously. Your colleagues have been sworn in, MEC. So because they've been sworn in, we can't accept the testimony from him. The best he can do is either maybe relay the information to one of yourselves, or else we can receive the information at a much later stage. Thank you, MEC.
Thank you very much, Commissioner. And I just wanted to add for the 4x4 vehicles, when the HOD was presenting, she was trying to put the challenge into context, having explained how we are struggling, especially as pastors. You can see that really it is very difficult to access our communities. And there was a slide that she reflected in terms of the population. You can see Sahrc with the least population, but in terms of the ratio and the scarcity where people can access facilities, it's a major problem. And we've been engaging in terms of the type of vehicles that we have. And we made a proposal. We've been engaging with Department of Transport as a department, and there has been progress in terms of getting 4x4s. They are not adequate. For example, at the government garage, we do have, there was a handing over which was done by our Honorable MEC of 54 vehicles. But the ones that are coming that are still at the government garage, they've been branded. There are still some few final touch-ups. There are about 24x4 Nissan vehicles. There are 6 dental 4x4 vehicles, and there are also 11 the other 4x4 type of a vehicle. Now, although we are excited that for the first time we would be having 4x4 vehicles, you can see the numbers. We have been expecting more, but this is what is currently at the Department of Transport. It has not been received by us. But what we are saying is that we are not sitting back. Hence, there was a slide that was talking to delivery of medicines for the chronic medication. But what we wanted to reflect on that slide was to say, although there is this program, but there has been an attempt now to ensure that we don't only focus on external pickup points that are in towns, but let's then identify areas like traditional councils, because even though the clinic might be closer, but in terms of the walking distance and the cost of traveling for the committee member to get to that clinic, a stable patient who does not require any kind of service except to pick up the medication, we have made progress with our partners. And we've got a lot of, especially traditional councils, King Kosi Joy, in OR Tambo, and all these that are upcoming on the slide from the Doctors Without Borders, and as well as the TB HIV Care Association. So at least in line with the National Health Insurance, if we are succeeding, because we are now starting with equity to deliver medicines at household level. I want to acknowledge that really this is causing a great challenge. I will mention one clinic that that it is very difficult in Xhekezweni. In Xhekezweni, if you go there, there's a bridge that when you are just looking at Xhekezweni, you can't even get closer there. Only services that, those communities that are there, they really struggle. Think of it, children and even pregnant women, especially during challenges with complicated deliveries or pregnancies. I don't want to use obstructed labor. So those are the issues that I wanted to add from my HOD. Thank you very much. Also,
That question, Dr. Carter, of how many mobile clinics that are 4x4, slide number 26. It's saying specific strategies to address health service delivery challenge. Mobile clinics, additional 54 mobile clinics vehicles further distributed to districts to make a total of 148 mobile clinic vehicles. Distribution of vehicles prioritize the most remote areas to improve access to address bed road challenges. 4x4 vehicles are procured, meaning that we have procured those mobile clinics are 4x4. 54.
Okay. Sorry, Chair, I just want to add another anomaly. We as a Department of Health, I don't know how many vehicles we own. I think in the submission on maintenance and all other information that we could not provide, Mr. Machokana would add how many vehicles we own, in particular on EMS, the ambulances, mobile clinics. Because the arrangement is that we rent vehicles from the Department of Transport, the Provincial Department of Transport. They've got what is called Government Fleet Management System. But what shocked me the other day when I got to be told that they don't insure those cars, those vehicles are not insured. So even the fact that we are complaining that they stay in a queue like any other vehicle of government being now taken there by the relevant authority or functionary Department of Transport. But they pay for them. You can imagine how much it cost that the government pay from time to time now, in particular on ambulances, if then they break down and they are not insured. But I think when we do our submission, we shall explain a bit in terms of that. I think it's another contributing factor, even on the time that they take in these merchants, where they are taken when now they have been involved in an accident, including other minor repairs that may be needed from time to time. Thank you, Commissioner.
No, thank you, MEC. Have you inquired why they are not insured?
But indlela asebenza ngayo transport uyazibhatalela when they. I haven't gone deep now because it's another function of another department. I was just shocked to hear that. Otherwise, that's what I was told by my officials.
Yes. And they don't, you can confirm that the health vehicles or fleet are not prioritized in the garage.
No, they stand in a queue like any other.
Like any other.
There is is it West Bank? There is a service provider that is appointed to attend to our vehicles as government general. And I think it's a national phenomenon, because I remember we were discussing it even in the National Health Council that is chaired by the minister, that we need a special arrangement for health. At least ambulances can't queue with like with other vehicles, even administrative vehicles, yet we know that they are dealing with emergencies.
Okay, no, thank you, MEC. Then let me hand over to Dr. Fobosi.
Thank you, Commissioner. Thank you. Thank you once again, MEC and the HOD and the department. Very much appreciated the opportunity to share this information with us. In one of your slides, you indicated that there's a total of 734 clinics in the province. And I would be interested to, that you share with the Commission that, as in how many clinics of that number are located in rural areas, right? That's number one. And number two, do you have statistics on the number of people who suffered due to unavailability of ambulances, right? Especially where the roads is not travelable, it's very bad, and that ambulance can't go, and even maybe the mobile clinic also can't go. So what happens as well in that regard? Another one, I was interested to just know on the budget that goes towards mobile clinics and EMS, especially in a financial year? How much is budgeted for in a financial year towards EMS and mobile clinics? Right? Also, in one of your slides, you mentioned that some of the ambulances are grounded. And what comes to my mind is then, what happens when such ambulances are grounded? What then happens? What is an alternative? Right? And also, one of your slides mentioned that due to the inability of the department to respond effectively to priority one calls in the rural areas, due to many factors, including rural infrastructure. And then I noted that you said due to many factors, including rural infrastructure. So, which other factors maybe besides rural infrastructure? Because you said due to many factors. And again, the second last one, what does the department recommend or to respond well to rural areas in particular? You know, to some of the conditions there. I understand that the mobile clinic is prioritized, but what happens in context where it's very difficult to travel? The mobile clinics can travel as well. And the last one, what happens, and I know that I've heard of some people saying this, what happens when one calls and is told that there's no ambulance? There's some people who have experienced that, right? They call the hospital and they are told that, look, there's no ambulance. What do such people do? Thank you. Thank you, Commissioner.
No, thank you very much. And this, maybe before you come in the MEC, this last question of Dr. Phobos is particularly important in relation to the number of persons per area to an ambulance. You mentioned HOD that the average is one person is 20,000 people per ambulance. But we are seeing here, if we take the numbers of the operational vehicles, for example, if we do our math, Alfred Nzo, it's about 32,000 people per vehicle, per ambulance. So naturally, you are going to have multiple instances where people are calling an ambulance and it's not available because the areas are also sparsely populated. So maybe the ambulance is 2 hours away, for argument's sake. So then this question, I just thought I should make that emphasis to that question, the importance of it. You've got then 31,000 people who, on a daily basis, if they are sick and need an ambulance, may not get that ambulance in Alfred Nzo because it's attending to another person. So what happens in that situation?
Okay. There is a question of total number of rural clinics. Yes, I was trying to calculate here to say I've got 72, 143, 152. I was trying to calculate to say the total number of the clinics in rural areas. Can you calculate for me here, Kip? Okay. When ndizama ukuhlula the rural clinics from the urban clinics, so where those numbers are excluding that calculation, is excluding the Nelson Mandela Metro and the BCM Metro. Maybe, Commissioner, when we answer, we might not be following your questions chronologically. Yes, I will start by the last question. When they call in the hospital and the hospital says there's no ambulance. The Department of Health has a call center. We do have a call center in East London, a call center in Chris Hani, where when you need an ambulance, you use that toll-free number to the call center. They have systems where they record all the calls that came requesting ambulances. That's where we can get our statistics. How many calls per day, per night? How many calls were responded to at what time in terms of the response time? That information is available. Then the call center, also when there is a complaint that I called, I didn't get an ambulance, they're able even to SMS, to WhatsApp, or even to send, to call and say, and lay their complaints. Those complaints are categorized to say, these are ambulance calls, complaints, these are from this area. Then immediately, as a district manager, we get that information. Immediately, as the caller is on the call, the call center agent calls the district manager, knows where to channel that. District manager so-and-so, there's a problem in an area so-and-so, they've been asking for ambulances. The ambulance is not available. There was a system that was being used also by the other district that says, any clinic that is any patient can say, please call ambulance, a message like that, please call ambulance when there's a problem. And then a nurse in the clinic or a sub-district manager can respond to say, okay, ufune ambulance, klo area. I used to be a district manager. I would get message that says, please call an ambulance. I will know that this person is in trouble, she needs an ambulance. How are they getting this information? Each and every clinic and hospital or CHC, on the door, on the top of the door, the name and the contact number of the district manager is there. So when they're in trouble, they just call, please call an ambulance. They do that, please call an ambulance. There's a DM, you know, okay, you call that person, what is the problem? Then you call the call center. Yes, there are delays because there are few ambulances, ma'am. Definitely, it's a serious challenge, and the delays in getting there due to poor road infrastructure. The department, as you have mentioned, that these calls of these ambulances are recorded, and we know where are the challenges. Then when the performance reviews are done quarterly, all those challenges are presented there. They don't even wait for the quarterly performance reviews. There's a part presented by EMS monthly in the district management team meeting where these challenges are discussed. We have got what you call a district advisory committee where these challenges are brought there and discussed. And there's a sitting called District Health Council where there are politicians. They come with the community challenges also there, meaning that there's a follow-up where there's a challenge. With the 4x4 mobile clinics, they assist a lot. And the patient vehicle transport, taking patients to from nearer. At times, these are assisting because in a health center, that patient vehicle transport will fetch the patient at the call center to the nearest hospital. We make use of them at times when the ambulance is not available. It doesn't mean when the ambulance is not available, there's nothing that can be done. All means and ways are done. The use of private ambulances, when there are times of crisis where it would be clear, the head office would be saying, area so-and-so, it doesn't have ambulance. They're in repairs, we're functioning maybe with 2 or with 5, they would tell. And then there is an arrangement done by head office to say, we're gonna be using Elderson, maybe, I'm making an example, sorry to mention the name of the company, any private ambulance that the department has got an MOU with would be made use of when there's emergency. It doesn't end to say there is no ambulance, then there is no ambulance. An arrangement is done, the district manager phones head office, please, we are struggling. We would make use then of the private ambulances. White fleet again. Hospitals have got white fleet, that is I've made mention of the white fleet. If the transfer doesn't need a stretcher or a mode of ambulance, kind of, when there's an emergency, a white fleet is used to transport the patient, escorted by a professional nurse, quickly to the next care. We don't just because there is no ambulance. The other question was, that is also answering, Commissioner, that question that says, it means if the population of so much is depending on 20,001 ambulance, it means if there are many calls, nothing can be done. Something can be done, Commissioner. I answered the one of what does the department respond to rural areas and what happens when, in terms of health services. Satellite clinics, we made mention of them because it's difficult to travel to that clinic, or maybe now due to crime, or there is a river now that is overflowing, or there's a forest that has established itself. Now people can't cross that forest. We make use of the satellite clinics. The identified places where it's hard to reach to the clinic, the nurses would visit there twice or once a week. Then the people will be able to access the health services through satellite clinics. Yes, that is, I wanted to respond on that one. What happens when the ambulance is on the ground? That private ambulance also is of assistance, but it is controlled. You don't just call and say, you don't just call straight to the private. You go via the Mr. Munilal, who is responsible for that. There was a question on how much budget then, and yeah, she wants to add.
Through you, Commissioner. Yes, thank you very much, Commissioner. I just want to respond to the question of what happens when there is absolutely no mobile vehicle. Committees cannot access anything. What the department has done is to form partnerships with various groups. For example, let me cite Inqanga. Inqanga is a group of medical professionals, specialists, physiotherapists, all types of specialists that are not even available in our clinics according to our primary care package. I will make an example about Alfred Nzo, where we've been implementing this partnership. Even now in December, they are going to Krisan in a very rural area, and we go in partnership with them. We mobilize committees and we go to an area where there is a challenge like access, because although I've indicated that there are additional 4x4s that are coming, but still they would not address the issue, the question that you are asking, Doc. So what I'm saying is that when we went to Nopoi in Alfred Nzo, that is a Mount Frere, very rural area, and we had a problem to transport them, but people come on their own. And when you looked at the number of people that were looking for these services, and they accessed different types of services, and even identifying patients who they didn't even know that they had hypertension and some urgent intervention that is required medically. But that, and Alfredo has been we've been very involved in terms of conducting. There's a Tumamina where as a department we mobilize and we go to that area. You find that this area is just an isolated population that really, even if you can have an ambulance, it is very difficult to go there. Now, if I speak of Alfred Nzo, that translated into very good outcomes, health outcomes. And I want to mention that we've got something that we call the 95-95 for HIV. They are the first district that have achieved that cascade of HIV and TB. And even the TB success rate, they are topping because of the access, improvement in access by ensuring that professionals, what I need to indicate is that, Commissioner, these doctors, they come voluntarily. They have got they make time free of charge, and we're finalizing the memorandum of agreement. And for us, I think that is when our MEC said, this must not just be the way we are doing it. Let's formalize this because it has got great impact in terms of how we are offering our services. I think HOD has spoken to the issue of the rural clinics because urban, it's Sahrc and Nelson. I mean, it's Nelson Mandela Bifi. But I wanted to talk to the budget. There was a question of what has been allocated for Program 3, which is our emergency medical services for the current financial year. We've got 1.5 billion. I can just summarize by saying that for the current, which is 2023-2024 financial year. Thank you.
For mobile clinics, how much?
For mobile clinics. For EMS?
The question was for ambulances and mobile clinics. So you're
Oh.
saying for ambulances, it's 1.5.
No, okay, no, I was, sorry, MS, with all due respect. I had thought the question was how much has been allocated for the EMS services. So my response was to say for Program 3, that is EMS, it is 1.5 billion. Then the ambulance, the mobile vehicles are from the district health services allocation, which is with the adjusted appropriated allocation, we are having an allocation of 14 billion. And those services, that is the mobiles, are procured within Program 2 district health services. MEC, Commissioner, sorry.
Just before MEC, there are other service providers, I would put it community-based NGOs across the province and other partnerships across the province. We are having partnerships with community-based NGOs where the department gives money to that particular NGO that is community-based and do some community-based services in that particular area. I'll make an example of tracing TB patients that are defaulting, tracing children for immunization, bringing treatment home. There are also those partnerships across the province, and they are funded by the Department of Health. So I'm not sure how much per CPO you are paying from the conditional grant. There are those partnerships across. We do have partnerships with bigger NGOs. Across the province, all the districts are supported by the NGOs that are having a budget from the PEPFAR and the Global Fund and all those big NGOs. That comes, the budget that comes from, I'll make an example, American funding, they would come and assess, and we seek meetings. They do monitoring and evaluation of the budget that they are giving to the Department of Health. Those services are more specially for the TB, the HIV, and the cancer. There is partnership with with another NGO for mental health. I'm sorry, not cancer, mental health. So there are partnerships across the province, so that the Department of Health is not doing these services alone. For mental health services, the Life Asset Money has an MOU with the Department of Health. Money is deposited there to take care of mental health services that the Department of Health maybe don't have enough space for those chronic mental cases across the province. Thank you, Ms.
So in short, Commissioner, we shall provide the information, the detail on how much budget per annum for mobile clinics and how much budget per annum for ambulances as part of what the DDG was trying to say, how much is available on this program, and not specifically talking to that. We've got good partners. Abokiredi, small projects, foundation, right to care, beyond zero, Mumbingomso. There are others internationally funded. We've got one, what is the other one? The one that is helping Yanden now with a mobile clinic, one-to-one. So there's a lot of other partners that join hands with us where we can't reach. We've got also programs like your community health workers, where they do the promotive, preventive, educational. They go to the communities, identify the needy individuals so that they can be helped by bringing those services to them, or arrange that they can go to facilities. So it's not only waiting for them to come in fixed setup like clinics or through ambulances when they call. So there's also door-to-door of some sort that we do. Hence, we are strong now to say, because the community health workers, they are a cadre that in South Africa is not yet recognized, and as such, they are not appointed permanently. But we have since taken a decision with the National Health Council, I think last financial year, it was a year-on-year contract arrangement that we've been, I think we've got more than 5,000 of those in the Department of Health in the Eastern Cape, but it's a lot of them. So we took a decision now that we shall formalize their appointment. It was said, let's use 3 years instead of 1 year, so that you can now transit to making them permanent. But because of minimum requirements, others of those community health workers have different minimum educational capabilities. So the Department of Health nationally is trying to come up with standard norms that can be used as minimum requirements. I think the issue of the clinics, how many are rural, also we need to give information, because we mustn't talk about rural towns, we mustn't look at the districts, because in the districts you get towns. So if you want to know how many are based in the wards at rural area, I think our submission issue must be specific, unless the one that we are pointing at goes to that level. Mustn't take like BCM and Nelson Mandela are urban, then Mthatha and others are rural. Rural means where it's even hard to reach. So if you can have statistics that talk to those. But it must also be noted, my commissioners, that the Eastern Cape has almost close to 1,000 facilities, be it the health posts, mobile clinics, fixed clinics, hospitals of different levels. And it's got the highest number of these facilities in the country. Even the hospitals, I think we've got about 92. If you look at Gauteng, they've got about 30-something, if it's even 30-something, or it's less than 30. So even that is a challenge in terms of infrastructure now, because some of these facilities were donated to us. There's a clinic that I attended to at Kokama in Sahrc. It's one of those, it's just an example. It's a wooden structure. It's called Woodlands Clinic. It was donated by the communities. It was a soup kitchen of an NGO. Now, because they need these services, they say, no, we're donating this structure. Once you take it as your clinic, you must now try to make it an ideal clinic. So you get clinics whose infrastructure is not adequate in terms of the ideal clinic, in particular now that we are going towards a NHI. But having many of them also is a challenge to us, because we still talk about staff shortages, yet about 19 billion rand of our budget goes on COE. Of the 19 billion rand, we get left with 9 billion. I said the 4.6 billion rand already is accruals. So we only got about 5 billion for the actual service delivery that you must provide as the department. But at the same time, the number, I think we've got about 52,000 employees as the department. But still, we are short. There is a lot of vacancy in our facilities. So we are facing those challenges, but we are doing all as my officials, HOT and DTG, have shared with the commissioners on the work that we try to do. The other issue, I think as a person who now is a representative of the people, I stay in the Lallies there, the reality is we get the reports that sometimes the people who lose their lives when the ambulances don't come, but sometimes people make means to hire, even if it's vans, if it's in the rural areas, a van that can take a person to the nearby hospital. So even though we try, it's not all the time that we win to say everybody who then requires or calls for an ambulance, all the time we are able to assist those people. But I don't know if my DDG and HOD did respond to the specific question of Commissioner Doc on the issue of saying, you said there are times when the ambulances are not available because of many reasons. And the other reason was the inaccessibility because of the rural nature of the province or rural infrastructure. What are other reasons that may lead to an ambulance not being available? But we have taken a decision this financial year that we shall even look at the issue of decentralizing the ambulance centers, because we've got the centers bases, ambulance bases, that sometimes are scattered all over. But we find that sometimes they are too far from where the people are. So we said we'll try by all means to decentralize. Don't say if you are from Krisani, the only base for ambulances maybe is Komani. Try to decentralize that, those ambulance bases. So we are trying. But as I learned, I was impressed when I went to Jokabi, because Jokabi is the only district that does not have the higher levels of care in terms of the hospital services. It's only got district hospitals, which is level 1. They don't have the regional, they don't have the specialized, they don't have the tertiary or central. But they've got an arrangement that I think we need to come closer to it, where they go. There are rondavels in a hospital. Is it Taylor Bequest, Mount Fletcher? They've got rondavels that are in the hospital where they go even in a period more than a month before the due date. They go and sit there and will be cared for, even though they are not admitted in hospital, to avoid any other emergency that may happen. And I'm told that is very impactful. But it's something that I think we are yet to try to expand, to try to assist it. So people they've got their own also means of trying to meet halfway that what the government is doing for them. Thank you, Commissioners.
No, thank you, MEC, and apologies for the energy, but I think we can all agree it's a burden we all share. It's a national burden. Just maybe, MEC, if you can assist me here. I'm looking at slide 10 of this presentation, where we have the list of the ambulances. Now, these numbers, if you just look at the ambulance numbers on slide 10, and then when you go to slide 13, where it's also listing the ambulances, acknowledging that we've got some vehicles that are not operational, but you have that column where you are counting your total vehicles. And these numbers here, which is the second column, these numbers which depict the number of ambulances that you have is different on slide 13 to the numbers you have on slide 10, which depicts your ambulances, to the effect that the total is 447 on slide 10, and the total is 444 on slide 13. Are you able to assist us with that differentiation?
Commissioner, if you look at slide 13, it's total vehicles. It's total vehicles. The slide 10 is 447 ambulances.
We will give you the opportunity to consult the gentleman. I think he's saying he sent you a WhatsApp. So maybe you can just consult him.
Can we
And then,
consult?
yes, you can.
Thank you.
You can consult him and then you can respond. It's just that he's not sworn in, so he can't speak. So maybe he can assist.
Thank you, Commissioner. 447 and 444, 3 have since been written off due to accidents or damage deemed costly to repair. So maybe we should have a narrative to that effect. Why 444 instead of 447?
Okay.
Can I make a disclaimer, Commissioner? Unless there are different years that are put on the slides, apologies on that. I almost gave up on help with numbers. I don't know if people of this department, they don't do maths. If they give you numbers, there's always a discrepancy in terms of numbers. Even yesterday, I was shocked to hear the number of clinics. So the last time I knew we had 744 clinics plus 52 CHCs. Now I saw 737. We're at the portfolio committee. I even see another number. So apologies for that. We'll try to reconcile forward the correct number. How many ambulances do we have? Because if then it was 447, it must be under a particular year. If then we're reporting today, but we're reporting 447 and 444, there's something that is not right. So apologies for that. We shall try to correct it.
No, it's fine, MEC. It also then questions the integrity of all of the other numbers, even if they are correct, you see. So thank you for pointing to that. Then maybe when you send the outstanding information, you can also just check if all of the other numbers are correct, and then just update them. But the information you have given this afternoon has been quite valuable, and we appreciate it very much. I don't know if Dr. Phobos or Dr. Carter have any follow-up questions. Dr. Carter doesn't. Neither does Dr. Phobosi. Then, MEC, let me allow you the opportunity to offer us closing remarks, if you have any, before we end our engagement with yourself this afternoon. Over to you.
Thank you, Commissioner and Commissioners, for this opportunity. We always respect and appreciate being called to these important institutions of our democracy. And we are, thank you.
No, thank you very much, MEC. We appreciate your time as well, and we appreciate that you are working under a very challenging context. We can only wish you the best. And we serve a common client. The people that you serve are the very same people that you serve. So it's in our interest to work together so that we can explore ways in which we can make the situation better for the citizens. So we really thank you all for your time, and we wish you all the best. You may now be excused, MEC, HOD, DDG, and the late gentleman. Thank you so much. Thank you so much. This then also brings us to the end of our program for the day. The time is now 1 minute after 4. We are adjourned, and we reconvene tomorrow at 8:30 or at 8 o'clock, sharp. Thank you. Good afternoon.